I think, and
Bhagyashree
yes.
is luck.
Oh, that's luck. Okay. What the live is starting right now? It's started. Okay.
Oh,
So relax. Hello everyone. Welcome back to Virtual Dental Challenge session. Today we have Dr. Bhagyashree with us today. She's a periodontist, and the floor is yours. Feel
yeah.
free to take
Thank you
over.
so much, Scott. So, hi everyone. My name is Dr. Bhagyashree Bhargude, and I completed my master's in periodontics in 2020. To In 2010, I admitted to this Krishna Institute of Medical Sciences, which is in Karan. There, I completed my 4 years of dental education, my undergraduation, and followed by 1 year of internship. After that, I worked for 2 years in a private dental clinic as an associate dentist. And I gave my, doing my part time job, I also applied for the NEET exam, which is a national entrance exam in India itself. So I passed, I cleared that exam, and I got I got a seat in periodontics in Yashwantrao Chavan Dental College, which is in Ahmednagar. And after my completion of master's degree, I am currently working in Dr. Uday B. Shetty's clinic. There I'm working as a periodontist as well as an associate dentist. So, to know about my story is a bit weird because initially I actually wanted to go for engineering and not in a medical field. I had biology, but I had a biology as a subject in 12th standard as well. And I don't know how, like, because of God's blessings, I guess I scored more marks in biology subject as compared to my physics and maths. And after I saw that, like, I'm good in biology subject, so I came to know about this bachelor's of dental surgery course. And I interviewed a lot of doctors. I inquired about it, like how is the course and what is the scope of that course in future. So they told me that it's a very good thing. It is not as hectic as the medical field. Like, it does require there is a more of a physical job, but the time is very much like under your control. Like, you don't have to go at 3 a.m., go to the hospitals and do any night visits. So it's nothing like that. So that is the reason why I opted bachelor's of dental surgery, because I wanted to balance my personal life and professional life as well. So, and in the first year of my graduation, I actually was very, very, very much scared because I was not knowing how capable I am, to pass the first year of, pass this exam only, like bachelor's dental surgery exams. So I studied a lot. I studied day and night. I did everything with the fear that I'll fail. I just wanted to pass in first year because it's considered in India, at least, the first year is very much hard. It is all about anatomy, basics, and everything. So I studied a lot. And to my surprise, I got a gold medal in the first year, and I secured first rank in the university. So after that, my journey began. After that, I started liking this dental course a lot. Then, as I told you, after my completion of graduation, I gave NEET exams and I got periodontic seat. And in India, unfortunately, I would say that in undergraduation courses, periodontic subject is mostly related to oral hygiene. Like, they don't have much of awareness about the subject, that it has other surgical procedures as well. Like it is not only related to oral hygiene procedures, cleaning, oral prophylaxis. It is not only related to that. It is all about the gums, bone contouring, about bone regeneration, and it has got a vast scope in that subject. There is a research work which can be done in this subject. There's a lot of research work to be done actually. So I came to know after I got the seat in this periodontics, and I started learning about it more and more, which actually gave me a lot of interest in that. So after I passed my NEET exams, I had the preferences, like choices. So my first choice of subject was prosthodontics. About everything, I was quite interested about prosthesis, and second choice was endodontics, because I had done a lot of endo cases in my 2 years of where I had been in the private dental clinic. There I had done a lot of endo cases. So my preferences were only that. But again, by God's grace, I got in perio subject. So yeah, and I started to explore this subject, and I liked it also, because I did a lot of research in this subject as well. Like, so my day, how is my typical day? Like, I see the first patient in the morning at 10 a.m. and I'm usually busy till 2 p.m. Later on, we get a lunch break, and then 5 to 8:30 is the evening session of the dental clinics, according to the Indian Standard Time. So most of the patients who come to our clinic, they come either for general dental checkup. Then if there's any pain because of the dental cavity, if there's any sensitivity, gum swelling, there's missing tooth. So these are the general patients who come for dental treatment. So the best part of my profession, I feel, is that I get to meet many people from all walks of life, other walks of life, and it's good to help them out and sort their dental treatment plan. But it's not that easy to convince the patient for, first thing, you have to convince the patient that going to a dentist is not a painful experience. So most of the patients, they have got that anxiety that, oh, dentist, and I'll be suffering now. I'll have pain a lot. And they end up sabotaging their dentition only later on. So that is the first step, to change their perception towards a dentist. So second is when you're planning their treatment, you also have to check what is the chief complaint, and we have to treat that first, and later on we can plan the other dental problems also for them, treatment for that. And also we have to see that we do not do more invasive treatment in the first visit itself, because patients are already scared and they are very much anxious when they come. So we have to see that we do something like minimal intervention in the first visit, which later on we can build up confidence with the patient, and then we can plan for other invasive treatment if it is necessary. And we also have to see at the same time that we are not financially burdening that patient, because dental treatment is very much costly. And plus, at the same time, we have to see that how we have to run our practice in a profitable manner, because there are a lot of investment which we are doing. Then there's a lot of financial thing which is going on in a dental clinic as well to run that practice. Yeah, so that is the most difficult part. But in the end, it is you have to keep it in mind that whatever you do is you have to do it best, what is like for your patients. And also we have to thrive our good business. So these two are the main factors which you have to keep it in mind while planning a treatment for the patient. So today I am going to talk about crown lending procedure. Like in frequently general dentists, they have dilemma that how, like, is it necessary to save those that tooth which is grossly decayed, like carious tooth, very carious tooth. How, like, is it like, how can we save that tooth, or should that tooth go for extraction? So there's a confusion at like in such cases. So crown lending procedure comes to the rescue if you are if you want to save that tooth, grossly decayed carious tooth, then crown lending procedure can help. But most importantly is you have to see how is the periodontium around the tooth, whether it is healthy or it is compromised. So accordingly, we will plan for this crown lending procedure for the tooth. Now, what is crown lending procedure? If you see, according to American Academy of Periodontology's glossary, clinical crown lending procedure is basically, it's a procedure where you expose the tooth structure for the restorative purpose, and this you can do either with the gingivectomy or by apically positioning the flap of the tissue. So when you're doing that, you can either remove the alveolar bone, that is osteotomy you can do, or you cannot. Like it depends. So what are the indications for this crown lending procedure? Now we will divide this crown lending indications into two parts. So first we'll see the restorative part. In restorative part, because of the caries, we see most of the crown height is lost. So it becomes difficult for us to, for us to get a proper retention of the crown in future. Like if you have to plan a proper PFM crown to the tooth or a zirconia crown, if the crown height is very less, the prognosis will be compromised of that tooth in future, because that thing, whatever treatment you are doing, it has to last long. Patient are going to invest in such treatment, but if the crown comes out like in 1 year or less than a year, then it's no point. So we have to see the long-term prognosis also of that tooth. So first is you have to increase the crown height, which is lost due to caries. That is the first indication. Second is, many of the times there is wearing away of the tooth structure. There is attrition, abrasion. So in such cases as well, you have to see how much of the tooth structure is lost and how you can, increase the height of the crown. Third is you have to check if the restorative margins you are placing, it should not violate the biologic width. If you do not check that, and in future if the patient comes with a gum swelling, then it will be difficult to manage. Then there will be another tedious task. You have to cut and remove the crown, and then again do some procedure. That will be more tedious, like for us, and it will be troublesome for the patient as well. So this is one of the restorative indication. Aesthetic indications, mostly people complain that my teeth they look short, or when I smile there's excessive gingival display. So in such cases, crown lending procedure can be done. So basically this procedure, it will provide a very stable margin, and it will also help in preventing further gingival inflammation. So I spoke about biologic width, but what is biologic width? Basically, it's actually a combination of a junctional epithelium attachment and the connective tissue attachment. So Gargiulo et al. And Vasek et al. In their studies, they have told the dimensions of the biologic width about this whole dentogingival unit. So according to them, the biologic width should be 2.04 mm. So they have given it in mm. And the average junctional epithelial attachment is around 0.97 mm, and the connective tissue attachment is 1.07 mm. So it is necessary for us to maintain that average biologic width. Like around, according to Ingber et al., it is around 3 mm which we have to maintain. So before going into that crown blending procedure, first you have to evaluate the tooth structure. You have to see what are the periodontal factors in that tooth and what are the restorative factors we are trying to achieve. Periodontal factors, we have to see how much is the width of attached gingiva in it, whether there is any furcation involvement, if we are gonna plan for a crown blending procedure, and if there is an osteotomy which is required. So how much, where is the furcation involved? Like how much of the tooth will be involved in the osteotomy procedure? That we have to check. We also have to check how much will be the crown to root ratio. It should not exceed more than 1:1. If it exceeds more than 1:1, then it can compromise the prognosis of their further treatment. Like if the tooth root is short and you are doing a crown blending procedure, it is no point. It will further complicate the situation in future. You also have to check the periodontium if it is healthy or not. If that tooth is periodontally compromised, if it's mobile, then it's no point in doing this crown blending procedure. And the most important part is you have to see how the patient compliance is, whether he is able to maintain oral hygiene or not. You have to check that pre-operatively as well as post-operatively. So these were the periodontal factors. So restorative factors which we can do is in cases of aesthetics, like where we just move the gingival margin apically and you see how the crown length has increased. If there's any subgingival caries present, then we can remove that. We can do it by gingivectomy, and we can remove these caries and we can restore it. And also for endodontic purposes, and you also have to check, as I said earlier, the anatomic factors of the tooth. Like if there is short root, if there is any cervical enamel projection which is present. So these all things you should evaluate before performing this crown blending procedure. Now, to make it more easier, there's a tree for treatment tree for doing a surgical crown blending procedure. So as I said earlier, width of attached gingiva is very much important. That is the keratinized gingiva. So you have to check the pocket depth of the patient. Now, if the attached gingiva is more than 2 mm, okay, that is considered in type 1 patient. And if the attached gingiva is less than 2 mm, then it is type 2. Type 1, like if you are getting a good amount of attached gingiva, the second step is you have to check what is the distance between the CJ or the final restorative margin to the bone. So you have to first decide the reference point which you are gonna do. So either it can be a cemento-enamel junction or it can be your final restorative margin. So you have to check the distance. Okay. If the distance is more than 2 mm, and if you do gingivectomy, then it's fine. There is no need for osseous reduction in these cases. If that distance is less than 2 mm, then you will have to raise the flap and you will also have to reduce it osseous. You also have to do the osseous reduction. Sorry. You have to do osteotomy as well in this case. Now, what will you do in cases where your attached gingiva is inadequate? If it is less than 2 mm, You can't do gingivectomy in such cases. If you do gingivectomy in such cases, again, you're compromising the periodontal prognosis of that tooth, correct? So if it is less than 2 mm, then other option is we can apically reposition the flap. So you have to again check the same thing, the distance from the CEJ to the bone. If it is more than 2 mm, then we can just do the apical positioning of the flap. And if it is less than 2 mm, then you will have to do osseous reduction, and apically you have to position the flap as well. So this is a simple treatment tree for aesthetic. So this goes for aesthetic purpose as well as the restorative purpose as well. Okay. I hope everyone is getting. Yeah. So, so after you do the surgical crown cleansing procedure, healing is very much important, because there's a phenomena called as tissue rebound. Okay. The person's biology, what do you say? Yeah, the person tries to person's tooth, they try to maintain that past biologic width. Once you do the crown cleansing procedure, they try to maintain the biologic width. So what happens in such cases? There's again the gums, they grow back to the original places, trying to maintain the biologic width. Okay. And there's a study, like according to Pontererio, they found that once you do the surgery, the osteoblastic activity after you do the osseous resection, it reaches at its peak at 3rd and 4th week. Okay, after surgery. So for the initial healing phase, okay, like for the initial epithelial attachment, it takes around 1 to 2 weeks after surgery for the initial epithelial attachment. Later on, for the connective tissue healing, it takes around 4 to 8 weeks. So as you can see, the soft tissue healing, it takes around 2 months for the soft tissue to heal. Later on, for the bone to heal, like for the periosteum, then for the maturation of that connective tissue, then it takes from around 3 months to 6 months. Okay, and for proper stabilization of bone, it is more than 6 months of healing is necessary in such cases. So that is why we have to wait after a crown cleansing procedure is done. Okay. So basically, for aesthetic purpose, if you are doing, then after you have to wait at least for 3 months for proper stabilization of your soft tissue and your bone structure, and then later on go for the prosthesis part, like if at all the patient is going further for laminates or any other crown thing. Okay. So, but we can, shorten this healing period as well. Like we can shorten this with our technical skills. So either we can do it with a flap position, like where we are trying to place the flap. We can shorten that healing period, or the second option is osseous resection. So according to Ernest Lee, like if you do osseous resection of 3 mm in a thin biotype, gingival biotype patient, or more than 3 mm in a thick gingival biotype patient, then we can ultimately reduce this healing period. So this is my first dental case. As you can see in the first picture, the crown height is very small. It's short. Okay, and her main chief complaint was when she smiles, her tooth, they look very small. And second thing is there's a gum display. Sorry. So what I did was, first I measured how much of the attached gingiva were present. So it was around 3 to 4 mm, which was quite adequate. Okay. Then I did the probing depth, and I marked the bleeding points, which is around 1 mm. Okay. So I marked the bleeding points and then I did a gingivectomy of around 1 mm. I gave an internal bevel incision and I did that gingivectomy. Now, as you can see, when I opened up the flap, there's the bone level is around like 1 mm below the CEJ. Okay. So now this is a proper case of altered passive eruption. Now, what is altered passive eruption? There are two types of eruption. Okay, there's active eruption, there's passive eruption. Passive eruption is where the crown has the crown has the crown has gone to the functional position. Okay, it's now in occlusion. The gingiva tries to migrate apically. So when it migrates apically, this is passive eruption. Now, if there's anything wrong in this process, then it is called as altered passive eruption. Like the gingiva has not grown apically, it's now at the same level, like in this case, how it is, which made her tooth to appear short. Okay, when you open up the flap, you can see the actual tooth size, which is quite long. So after flap liquefaction, you can see the level of bone. And after that, I did an osteotomy of 2 mm. Okay. And then I sutured it back. Yeah, sorry. So as you can see, now the crown height in the second picture, this is immediate post-op. It has increased as compared to the first picture. So this was this patient. It was an actual orthoperio case. So I did her surgical crown blending procedure, and then she had to go for an orthodontic treatment for further reclusion of her anteriors, which was causing excessive gingival display. This is a second dental case. This is a laminate case. This is a prostoperio case. As you can see in the first picture, the tooth height is also very small and there are a lot of spaces like diastema present. So her main chief complaint was not the short tooth, but her main chief complaint was to close these spaces. But when we evaluated, we found that the crown height is very small. So this is a pre-operative photograph. And as you can see, the attached gingiva was around 5 mm. We marked the bleeding points as usual. And we did 2 mm of gingivectomy in her case. So the length of the crown now, it has increased a lot. Then we raised the flap, and as we raised the flap, we saw the level of the bone was exactly at the level of CEJ. Like in few cases, in few teeth, they were 1 mm apical. After that, we did that osteotomy reduction about around 2 to 3 mm. And then we sutured it back. So after 4 months, we gave laminates to her, and this was the result after 4 months of healing. So these are the 2 cases which I presented today about crown blending. Now the question arises is when should we stop the osseous reduction? How much is enough? Because in some cases, if your osseous reduction is not enough, the tissue will come back to its original place to maintain that biologic weight. So around 3 mm is enough for any case. If you are doing an osseous reduction in such cases, 3 mm is enough. Okay, and also you have to check when you're doing an aesthetic crown blending procedure, you also have to check the incisal edge. Okay, you have to see where the incisal edge of the tooth is. Like if the patient is smiling, okay, if you see a young patient, if 3 mm, around 3 to 4 mm, 3 mm is seen when she is smiling. But same if you see in 40-year-old patient, the incisal edge displays very much less as compared to that. Correct. So you have to see everything. You have to evaluate about the lip, how the lip is positioned, whether the smile line, the curved line of the incisal edge, is it meeting the lower lip line or not? So all these are the factors which you evaluate prior to do any, like prior you do any aesthetic crown lending procedure. And then second is you have to check for the periodontal biotype, how it is, whether it is 3 mm or it is whether it is thin type biotype or it is thick biotype. So yeah, if you study, so most importantly is you have to study the patient's case. And if you do that, then you will succeed, obviously. So yeah. What is the hardest thing about being a dentist is, first thing is people, they constantly tell you that they hate dentists. They hate dentists a lot. Going to a dentist is suffering. Plus, you have to invest a lot of money in your dental education. You have to dental education for the materials, for your dental materials, for your books and for your instruments. It's like a huge investment. And the most weirdest thing we dentists do is we start noticing everyone's teeth. Once we are out of the dental school, we start noticing everyone's teeth. Whenever they are smiling, we first our vision is like, oh, their teeth, how is it? Is it crooked? Oh, it is bad. Oh, this is there. So we try to judge people with their teeth. Like, so that is the hard thing. And yeah, it is physically demanding as well. Dentistry is physically demanding, and dental practice is also very expensive. And even patients complain that dental treatment is very expensive, but the neglect is very expensive, not the dental treatment, I would say. And yeah, thank you so much.
Thank you, Dr. Bhagyashree. And I want to say that you're very, very brave because it's your first time doing a session with a American student, and I want to say thank you for joining us. We have a few questions here. The first question is, I heard that in Mumbai, dentistry is very competitive. So what is your experience and how did you stand out from the crowd?
Yes, because Mumbai is a dental hub, I would say. There are a lot of senior dentists, and they have already, created their own database, their own patient database. So you have to, if you have to establish a new clinic and you have to get those patients, it is very difficult. First thing. So first, what I did was I tried working with different doctors. I worked as an associate dentist over there. Then people started knowing my name. When I treated those patients, they started knowing my name. Oh, this is Dr. Bhagyashree. Oh, she works here. So with that reference, by word of mouth, like eventually, gradually, it happens. Mm-hmm. So yeah.
So basically, get your fame by words of mouth.
Word of mouth, yeah. Basically, okay. Yes.
And the question is, what are some other methods of replacing teeth other than implants?
What are? Sorry?
What are some other methods for replacing teeth other than implants?
So for replacing the other methods is bridge you can do. Bridge is where you take the support of the other two adjacent tooth and you place the missing tooth. So that is called as a bridge. Now, but for that also you have to check if your other two teeth, they are periodontally sound or not. If they are compromised, then the bridge won't be an option. So that is one. If you're going for a fixed prosthesis, if you are going for a removable prosthesis, then there's a partial denture which you can plan for the missing tooth. Mm-hmm. So there are different types also in that. You can do a cast partial denture or you can do a removable partial denture in such cases. Yeah.
Okay.
But implant would be your best option because it would be a long-term investment as well. And you're not harming the adjacent good teeth.
So basically, the good thing about implant is that you don't have to do other treatment on the other teeth for the bridge. For
Yes.
implant, you
You
just
don't have
need.
to
Mhm,
unnecessary grind a good tooth structure.
mhm.
So that is the good thing about implant.
And in your clinical cases, the second case, I think you said laminate, right? When you say
Yeah.
laminate, do you mean veneer?
No, laminates.
So they are not the same as veneer, but
Veneers
kind of.
are more thinner as compared to laminates, I feel. Laminates,
Okay,
the preparation is bit more in laminates.
okay. And do you think perio patient are suitable for veneers?
Um, that's a difficult question. Like if a perio patient, then you have to see how much is the gum recession if it is there. If there's a lot of gum recession, then laminates won't suffice, I feel. Then we
Okay.
might have to plan for other treatment option for that.
Hmm. So in case of a perio patient who wants a very aesthetic smile, what would you suggest the patient
I would suggest for a crown,
for a crown? Okay.
because with laminates you can't fill the interdental spaces.
Uh-huh.
In perio patients, usually they have got those black triangles. There's
Uh-huh.
recession, quite recession. So if then that is mostly the main complaint. Laminates is just you can close the
Surface layer.
yes, correct. And for the crown, if you do a crown, you can also give a pink ceramic which can imitate that
Hmm.
dental papilla. So that we can do in perio
So
patients.
what Dr. Bhagyashree is saying that when you're doing a crown, you can also create on top of the crown, you can also create the pink aesthetic, which is the gingiva part, where you can also make that part looks more appealing to the eyes of the people and fill in the gap of the black triangle. Is that what you're saying?
Correct.
Okay.
Yes.
And what are some common antibiotic for gum disease and the dosage, and usually how long do they take antibiotic for periodontal disease?
So common antibiotics which we can give is doxycycline. We can give.
Doxycycline.
Yes, we can also give augmentin.
Also, maybe metronidazole, right?
Yes, metronidazole, augmentin as well, which is a combination of amoxicillin and claminic
Hmm.
acid. So that also we can give.
And for doxycycline, it's also a type of tetracycline. Would you
Yes,
actually suggest that to be something beneficial for the patient since it probably stings the teeth for their maybe future baby, or you know what I'm saying? So
yes.
how
So
did you,
that
yeah.
that is not indicated in pregnant female patients,
Hmm.
but because that can affect the baby's teeth as well.
So
So
it's given to patient with who has already finished growing of their teeth and who is
yes,
not
yes,
pregnant. Okay.
correct.
And what are the effects of periodontal disease on systemic health?
See, it's an interrelationship. Like it's vice versa. Periodontal disease can affect your systemic health, and systemic health can also affect your periodontal disease. So,
Hmm.
like it's a two-way relationship. Like in diabetic cases, the sixth complication in diabetes is periodontal complication, where you
Hmm.
find multiple periodontal abscess in that. It also periodontal disease can also have effect on your cardiovascular health.
Hmm. Yeah, that's true.
Yeah. So like it's interrelated. It can in pregnant female patients it can also lead to a premature childbirth,
Hmm.
periodontal disease. So yeah, it's interrelated, systemic and this periodontal disease
Hmm.
both.
So basically, diabetes and periodontal disease go hand in hand because one
Yes.
will worsen the other if one of them is not controlled.
Correct.
Got it.
Correct.
And would you say, oh, never mind. Let me finish the questions here. So can flossing too hard create new periodontal pocket?
Sorry.
Can flossing too hard, let me see the question, create new periodontal pocket when you're
No,
doing flossing?
but the technique is more important
Mm-hmm.
rather than how, like if you are doing in a that saw action, if you are doing, then you might end up hurting your gum. So
Uh-huh.
there's a proper technique for a flossing where you properly place it in between your interdental area, and then slowly you go towards your cervical, like your sulcus area, and then
Uh-huh.
you do the crossing. So that is more important. People, they just push it,
Yeah.
do, so that is wrong.
That's
That
true.
is
That's true.
wrong.
Okay. So if you do it correctly, then it shouldn't be a huge problem.
Yes. Or you can
Okay.
use a water flosser if at all you're not comfortable with flossing. Water flosser can also be used in such cases.
But would you say water floss is enough for to cleaning, or would you say a normal floss is more it's gonna clean better?
Uh,
Like
I
would you choose water floss over the normal the line floss?
No, I would choose a normal flossing only.
Mm-hmm.
The water flosser, it is only for those people who are unable, like
Okay.
to do, which is tedious for them to do the normal flossing. So water flosser can help in such cases.
Okay. Got it. Mm, can you have periodontal disease without caries?
Can you have periodontal disease without caries? Yes, of course.
But
You can.
how could
You
you
can
get that?
have.
Because periodontal disease is usually the result of bad oral hygiene and maybe inflammation. So how does that overpass caries to periodontal
So
disease?
sometimes because of, in female patients, if you see, because of hormonal imbalance, like
Mm,
if there's any hormonal estrogen imbalance, so people, female patients, they come up with a, very big swelling, like
inflamed
redness,
swelling.
inflamed gingiva, and there are periodontal pockets as well. So in those cases, even if it is, the hygiene is clean, but the factor, causative factor for that periodontal condition is systemic, like the hormonal imbalance, which I said.
That's true. That's true. And is
Yeah, so it's
periodontal
not
disease?
necessary always.
Hmm. So basically, a pregnant woman will probably have some hormonal imbalance that causes the swelling of the gingiva, and
Not
that's
only pregnant women, also women who are undergoing irregular periods, PCOD
hmm hmm.
patients, where there is a lot of hormonal changes taking place. So in such cases as well.
And it's less commonly seen in male, right?
Sorry,
It's less commonly seen in male.
meaning male. Males, yeah, but in males also, because of the not the reason won't be because of the hormonal changes, but there can be other causative
Hmm.
factors like the bad habits, smoking, or other things as well.
Okay. And is periodontal disease contagious?
No,
It's not
it is
contagious.
not.
So,
No, it is not
okay.
contagious.
But the bacteria can actually be spread by kissing or other types of saliva exchange. Does that actually influence the risk of getting periodontal disease?
See, it's also, periodontal disease is also your immune response to the bacteria.
Hmm hmm. Got it.
So, how is that individual's immune response to the outside pathogen? That is
Okay.
also important. So, with, if you are kissing a periodontal patient, like apart from the bad odor, awkwardness, I don't think it is
Yeah,
contagious.
got
In
it.
such,
Okay.
yeah.
And what is the difference between gingivectomy and gingivoplasty?
Gingivectomy is you remove the proper
Hmm
gum tissue. Gingivoplasty is where you like reshape it.
Mm.
you, if at all it is thick in one area, if it is thin in one area, then you evenly you uh, do that.
So gingivalplasty is more of an aesthetic procedure.
Prosthetic, yes, yes.
Okay. And that's two questions. So, what was dental school like in India, and what is the process of getting into the school?
So you have to give after your 12th exam, you have to give a NEET exam, entrance
Mm,
exam, and then accordingly they will list on the online website like which colleges seat are available and which college can be allocated to you according to your marks.
uh-huh.
So this is one way. Second way is if you are going into private colleges, then there is another management quota where you can like for the NRI people, where you can apply for that. But then the fees would differ because in those the fees are much higher as compared to the people who go by NEET examination.
So, in India, you go from high school to university, right? You don't have to go through undergraduate,
Undergraduate, yes, you go.
but like you go from high school to dental school, right? In India?
Yes,
Okay,
yes, you go from high school to dental school.
okay, got it. And the last question is, so there are many dentists from India going to the international trained dentist program in the US. Would this also be a future goal for you?
I can't say. I mean, I don't know. For international training, like for educational purpose, is it
Yes.
he's talking? Yeah. So, like I have not much. I don't have much idea how to enter into that international educational system. But
Hmm.
yeah, I would love to. If I have to pursue a career, then I would love to do it in more specialized, like perioplastic or in implants. So yeah,
Got it.
there
And
it is.
you also say you want to build your own dental clinic in India.
Yes, yes, and also I have to open my own new clinic in India. So I will be investing a lot of money
As
over
well
here.
in India.
Yeah, and then like I won't be going to other foreign countries for long term, but yeah, for short term, and I would love to learn from their like dental school and then come and practice here in India again.
Got it. I think that's all the questions that we have for today. Thank you so
Thank you
much
so much.
for joining us, and the quiz will be in our link tree. So for the viewers, please take the quiz within 24 hours. And that's it. Thank you so much.